Well, that last video ended abruptly because I clicked on a wrong spot on my computer. So that was user error. So we're going to jump right back in to where I left off in chapter 13. We were going through the domains of language and how hearing loss impacts each of those domains. We'd already covered content, form, and use, or the pragmatic areas. Now we're going to talk about phonology, which would fall under form, but it's a little different in this sense because we're talking about sounds and how hearing loss impacts the acquisition of the ability to hear and produce sound. I think for the most part, that's pretty self explanatory. But let's explain it a bit. So, phonology will be impaired simply because one cannot adequately learn what one cannot hear. If a child is not hearing the sounds of their language, they will not develop the appropriate cognitive representations of those sounds, and so will not produce those sounds in a typical way. So, one of the hallmarks of what we perceive as deaf speech is that the speaker is replicating what they see from other typical speakers, not what would be heard if they had typical hearing. So, if you recall my student, Carrie, that I mentioned in the last video, I said just sort of in passing there was something going on with her speech. Something sounded off. Now, she didn't have the whole gamut of what we would call as deaf speech, but I noticed when I was doing my assessment that she had very soft production, so not a lot of noise involved of some of the fricative sounds, the S's and SH's. Um, she was posturing correctly for them, but there just wasn't a lot of noise associated with them. And that was a red flag to me, that maybe we were looking at hearing loss. Now, I didn't have to raise that red flag and alert anybody because the nurse was able to identify the hearing loss, but um, it should have been a red flag to the other people who were assessing her. So, other aspects of speech in someone with hearing loss may also be impaired and probably will. So, things like resonance. Again, they're not hearing oral nasal resonance, so they don't learn to produce sounds in the typical way. In fact, deaf speech does tend to be very nasal sounding. Also, speech rate and prosody, the melody of speech. We're not hearing it, we're not going to produce it that way. So this was where I was going to stop the last video, so we're moving on from there. Etiology, so classification, cause. How are pediatric hearing losses classified? Etiology always refers to cause, so that's how we're going to talk about it for now. 50% of congenital hearing loss, so present at the time of birth, is genetic, 50%. An autosomal, it's one word, AUTOSOMAL, autosomal dominant hearing loss, means that there is one parent that has a hearing loss and is a carrier of a dominant gene for a hearing loss. In that case, there's a 50% chance that their child will have a hearing loss. In an autosomal recessive hearing loss, both parents may carry a recessive gene. They may not even know it. Neither of them has a hearing loss. There's a 25% chance that their child will be born with a hearing loss. Congenital hearing loss, though, is not always genetic. Congenital hearing loss can also happen because of infection, illness, or injury during the pregnancy. It can happen at the time of delivery, or anything 28 days post delivery. So that's going to be our cutoff now for calling it a congenital loss, 28 days post delivery. So one of the things that may cause this is the use of ototoxic drugs. I've used that term with you before. Ototoxic means drugs, medications that people take that we know are toxic to the hearing. One specifically is aspirin. Now, people take aspirin all the time and don't have hearing loss. But if for some reason someone had to take or did take an excessive amount of aspirin, it can be toxic to the hearing, to your hearing. According to an ASHA paper, there are more than 200 identified ototoxic drugs that are currently in use in the United States and in developing countries. Specifically, some of the drugs that we use to treat serious infections, so for example, the mycin group of antibiotics, um, some of the drugs we use in chemotherapy for cancer, some of the drugs we use to treat heart disease are ototoxic drugs and can cause hearing loss in a developing fetus or shortly after birth or in an adult. And we'll come back to them again, obviously, when we talk about adults. But we save lives before we worry about hearing, right? Another cause of hearing loss in a newborn, brand newborn, would be noise exposure from ventilation systems, alarms, and other medical equipment in the NICU. If any of you have ever been in a NICU, a newborn intensive care unit, they're pretty loud places. There's all kinds of alarms going off all the time. Obviously, they have great ventilation systems. There's just lots of noisy medical equipment in there. And these little tiny newborns, because most of the kids in NICU are premature or they've got some significant health compromise at the time of birth. They have very delicate hearing apparatus, and that in fact you'll often see them with some kind of earmuffs on, and that's not to keep their ears warm, it's to protect them from the sound, so some kind of sound protection. But we do know that that noise exposure can damage their hearing. And then we talked about age of onset. This is not a cause, but age of onset, I want you to always remember, is a factor. So a prelingual hearing loss will be much more impactful than a postlingual hearing loss. And again, there's no clear delineation of that age, but the more typical speech and language development a person has, the less likely a hearing loss is going to be to compromise communication in a significant way. So we can also classify by type of loss. So if you remember back to chapter 3, the structure of the ear, and I'm going to go through, it was a test question, that acoustic energy coming into the outer ear, which then it turns into mechanical energy in the middle ear and to hydraulic energy and eventually to neural energy within the cochlea. So think about those inner ear structures and the auditory nerve. This is information I need you to remember. A conductive hearing loss results from damage to just the outer or middle ear. So the middle ear being the tympanic membrane, the three little bones within the middle ear, okay? So damage to the outer ear or the middle ear. It's only a conductive hearing loss if we have an intact, functional inner ear and cochlea. Okay, they're functional. Everything's good, but we've had some damage to the outer ear or the middle ear. Then what's it called? A conductive hearing loss. A sensorineural hearing loss is when there's damage to the cochlea or the auditory nerve, so the inner ear systems. But the middle ear and the outer ear are intact and functional. Okay, so these are exclusive hearing losses. 1 to outer and middle, conductive. 1 to inner ear, auditory nerve, sensorineural. The other systems are fine. And then we can have a mixed hearing loss. So obviously someone with a sensorineural hearing loss can then get a middle ear infection that's going to result in some conductive loss. So those are damage to both systems will result in a mixed hearing loss. How does hearing loss look? What are the manifestations? So we look at, is the loss significant? Is it just slight? Mild, moderate, severe, profound hearing loss? Is it happening in one or in both ears? That's a huge part of this. Is only acuity affected, meaning just, I can't hear that sound really well? Or is comprehension and perception of language affected? So there's that distinction again from the definition of are we just detecting or are we distinguishing language? Hearing aids, by the way, make up for loss of acuity. They help us hear things, they help us detect, but they're not as beneficial for that loss of perception or loss of being able to distinguish sound. In terms of severity, we measure severity of loss. Think severity of acuity. So we measure that in decibels, the standard measure of sound intensity or sound loudness, decibels. Threshold, this term threshold, is the earliest point or the lowest decibel at which a person can hear. Now, for normal hearing, for typical hearing, threshold can be between -10 and +15 decibels. We consider that typical, normal. Although, if you were doing a hearing screening, passing a hearing screening is at 25 decibels. In your book on page 450, there's a chart of levels of severity related to threshold. So please be familiar with those numbers. Again, page 450, the chart of levels of severity related to threshold. So be familiar. Hearing loss is plotted on a graph called an audiogram. At the top of page 459, there's the first example of one of those. You'll see them again. Pitch range is across the top of the audiogram, and decibels are along the side. The one that you see on the top of page 459 is not plotting someone's hearing loss, but what it is showing is where specific speech sounds fall on the average across frequency and pitch. So if you compare that information with the information regarding severity on page 450, you can see the impact that a mild to moderate hearing loss would have on the sounds of speech. So, for example, someone with a mild hearing loss, so that's 26 decibels to 40 decibels, may have difficulty hearing or distinguishing the fricative and affricative sounds. So the z, the v, the p, g. Those are not fricatives or affricatives, but they're the voiceless sounds. K, s, f, the th sounds. The audiograms on page 459 to 460 show the plotting of someone's actual hearing pattern. The defining characteristics of types of hearing loss. So back to our types, conductive, sensorineural. Conductive loss. The hallmark characteristic of a conductive loss is sound attenuation. More simply said, it's just a reduction in the ability to hear sound. Everything is quieter. So, for example, if you take cotton and put cotton balls in your ears, you will still hear sounds. It's just that everything is much quieter. You will miss some sounds, but you'll hear if the sound is loud enough. And that's a conductive hearing loss. With a conductive hearing loss, a patient that can talk to us will report that their ears feel full. The sound of their own voice seems louder or exaggerated to them. And this is because of bone conduction, which is the transmission of sound vibration along the bones of the skull. I think I've mentioned this to you before. If I haven't, it's okay. I'll mention it now because I know you've all done it. This is, plug your ears and talk, and your voice will seem louder to you. If you go underwater and talk, your voice seems really loud. So we've all laid back in the bathtub so that just your ears are covered, and then you talk. Your voice seems really loud. And this is because of that vibration of your voice on the bones of the skull. So bone conduction. A conductive hearing loss will always be in the mild to moderate range, and that's because of that bone conduction. Once a sound is loud enough, a person will hear that sound. A true conductive hearing loss, cochlear function is intact. So sounds, although they're attenuated so that they're dampened, are still getting through to the brain. Most conductive hearing loss can be addressed medically, which means it's temporary. There's a very rare instance where conductive hearing loss cannot be, and we see that in adults. We'll talk about it with adults. Causes and risk factors for conductive hearing loss. The most common, I shouldn't say that, a common cause is just buildup of wax in the ear. So there's a blockage of the external auditory canal due to a buildup of wax in the ears. That's one of the causes. And there's also the cause of outer or middle ear malformation. The most, oh, I'm sorry, I'm stumbling over my words for some reason. The most common cause of conductive hearing loss is otitis media, the middle ear infection, but it can be caused by cerumen blockage or outer or middle ear malformations. With otitis media, 70% of children will experience otitis media. 40% of them will have chronic, so repeated episodes. Otitis media can be controlled with antibiotics or with the use of pressure equalizing tubes, PE tubes, inserted through the eardrums. So the risk factors for developing chronic or developing otitis media, just biologically, the eustachian tubes in small children are at an angle and a length that's short, making for easy access for bacterial organisms to enter. If you remember, the eustachian tube connects the back of the pharynx with the middle ear. In an adult, that's quite an angle to get there. But in a child, if you look at a child's face, that angle is not as of the same as when they've had full growth. So and the tube is very short. So if they've got that horrible stuffy nose and they're blowing their nose or they're sniffing all the time, that bacteria can get to the middle ear pretty easily. There's also environmental risk factors such as exposure to allergens and exposure to smoke. And then just the environmental risk factor of things like group daycare. The reality is we need to put our kids in daycare if we're going to go to work, but there is also a risk they're going to be exposed to more bacteria. Microtia is the term for a missing or malformed outer ear. Sorry if my earring's distracting. Microtia, missing or malformed outer ear. And then atresia, if there's also a malformed ear canal and middle ear cavity, including the ossicles. So microtia is just the outer ear. It becomes atresia if there's malformed ear canal and middle ear cavity. In my career in the public schools, I've had a couple kids with microtia. Neither of them had atresia, but they had microtia. So it is something that happens. Sensorineural hearing loss. This is the most common type of hearing loss. Please don't be confused with what I said a minute ago. When we were talking about conductive hearing loss, the most common cause of conductive hearing loss is otitis media. Now we're talking about sensorineural hearing loss. This is the most common cause of hearing loss. It is damage to the cochlea or the auditory nerve. Outer and middle ear, fine. They're functioning just fine. A sensorineural hearing loss can be slight all the way to profound, where we would call it deaf, okay? So it can be in one or in both ears. It generally involves a decrease in loudness, so that same sound attenuation, but it also involves a decreased ability to perceive speech sounds and to distinguish speech from background noise. Sometimes it's accompanied by tinnitus or tinnitus, that ringing in the ears. It can also be accompanied by a reduced tolerance for loud sound. So a person with that hearing loss, if there's a loud enough sound that they hear it, it's unbearable. They just can't tolerate it. Hearing cannot typically be restored in any kind of sensorineural hearing loss. So that's what makes it very unlike a conductive loss. This is not going to be a medical management. We're not going to restore hearing, but it's managed by amplification, so the use of hearing aids and other types of interventions that we'll get to. The causes and risk factors for sensorineural hearing loss. Most often in a child, remember now we're talking about children, most often a child identified with sensorineural hearing loss it is congenital, so it was there at the time of birth. That's the most often cause. Now, it can also be caused, I'm going to back up a minute, stick with at the time of birth, congenital. So this is illness, drug use, or medical problems of the mother during the pregnancy that's resulted in this hearing loss. In utero infections, so things like any of the sexually transmitted diseases that the mother may have can result in hearing loss. Complications during the birth process, so just poor infant health or oxygen deprivation can result in hearing loss. Family history, so there's the genetic piece, and then noise exposure, which we already talked about a little bit. But most often, sensorineural hearing loss, when we see it in a child, is congenital. Hearing loss can come along with any of the syndromes associated with craniofacial anomaly, or for example, Down syndrome. Often kids with Down syndrome have some degree of sensorineural hearing loss. Sensorineural hearing loss, though, can also happen with otitis media, that middle ear disease, middle ear infection, but only if it is recurrent and it's persistent and it has that effusion, the buildup of that gunky, I want to call it liquid because it's not, but it's that sticky, gunky buildup in the middle ear. If that lasts for longer than 3 months, it could result in that infection then impacting the inner ear, and at that point we have a sensorineural hearing loss. In 57% of cases, the cause is unknown. In the remaining 49%, the leading cause of sensorineural hearing loss is genetics. And then a mixed hearing loss. I've already stated this once, but obviously a child with a congenital sensorineural hearing loss can also have a conductive loss. They can also get ear infections, and then they'll have a different kind of hearing loss on top of the already present sensorineural. On page 494, there's some information on cochlear implants. Take a look at them. We're not going to talk about them right now. We'll probably talk about them more, I think, in the chapter on adults, although we might get to it again in this chapter. But take a look at those. All right, I'm going to end this video right here.